So we've talked about pre-op, we've talked a little bit about intra-op, and now we're going to talk about post-op. And so post-op nursing is something that's very, very important to think about because any patient or client that has had a procedure, if it's a minor surgery, a major surgery, no matter what kind of surgery it is, they're going to come back and they're going to need the nursing care that needs to be provided. So if it's a post-op major surgical patient, you're going to want to know the basics of that. Then if it's a neurosurgery, let's say, your focus will be on neuro. If it's a abdominal surgery, then your focus will be on the GI tract or the abdomen. If it's an extremity, the extremities, and those get more specific, but you want to understand the basis because every patient that comes back has been put under anesthesia under major surgery and has to wake up. And these are the things that we need to do. So let's get started. So I'm not going to read these all to you. This is just telling you what you need to understand and learn as you go through this unit of post-op care. And you can take the time to look at those yourselves. Of course, you have your clinical practice objectives, and these are very important. Always prepare to perform an immediate post-op assessment as soon as they enter the door. Matter of fact, I like to do mine before the nurse, if a nurse comes with that patient, I like to already start assessing while the nurse is standing there so that I can ask questions to that nurse directly. If it is a actual person that is bringing them from the OR that is not medical, then they're not really going to be able to assist or help you. But definitely immediately get on that post-op assessment. Also pain, and we're going to go into more pain and how to control pain in the mobility and pain unit. But for now, you just have to know and understand that anybody that has been cut, it's going to hurt. And anything been digging around in there doing stuff, it's going to be very painful. So we need to make sure that we start to understand the pain part of that and to assess for pain. So of course, to add to that, we want to promote early ambulation, and we have discovered that if we can get people up and walk them as soon as we can post-op, they do much better. It's painful. It's hard. They don't think they can do it. Sometimes you wonder if they're going to be able to do it, but I will tell you, by helping them and getting them up, movement is the key. We are made as human beings to stand upright and move. If we can do that, we need to do that. So that is one of the best things we can do. Also, when do we start discharge teaching? The minute they step in the door to anything, we need to start teaching. If they are someone that's coming in from home directly into surgery, when they met to do their pre-op, that's where you start that discharge teaching, but also to definitely give them the post-op directions and make sure that they're very, very clear so that when they leave you, they'll be able to do what they need to do to successfully recover from the surgery and get back to their normal state of whatever it is. So after surgery, the patient usually will go to PACU, which is a post-operative recovery unit. So what we're wanting is we want them to recover there immediately after surgery. Then once they're stable there, it can be 1 to 6 hours that they're in PACU. Then once they've stabilized, they'll bring them then back to the floor for the nurse, floor nurse or ICU nurse or whoever to assume care. Now, there are some surgeries out there, guys, that they don't go to PACU. They go from the OR to the ICU, and that's open heart, and some of the neurosurgeries will come directly to the units for those nurses who have been trained to recover these patients specifically. But the majority of surgical patients out there will be operated on, and then they will go to PACU, and then post PACU come back to you as the nurse. So if they're in PACU, the first thing is the PACU nurse will get a report from the anesthesiologist or the nurse anesthetist from the OR themselves. They want to know, how long, how much, if anything happened during the surgery. The anesthesiologist is the person who knows. They are at the head of the bed, and they kind of control what's going on as far as those things are concerned. They're the overseer of the surgery. Attached, you're going to immediately attach them to a heart monitor, and you want a pulse ox, because these patients have been under anesthesia. So we want to hopefully wake them up, get that breathing tube out pretty quickly. Most patients are pretty groggy when the breathing tube comes out. They don't even really remember it, but they're able to breathe on their own at that point. But you definitely want to monitor them, heart and breathing, pulse ox, so we know if they're oxygenating or not. Sometimes if they're very sleepy, what happens is anesthesia will relax those muscles in the jaw. And so even in conscious sedation, where we're not really going to be intubating this patient, but we're giving them good medicines to relax them, to do things, procedures on them, the jaw will relax back, and the tongue, and they'll occlude their airway. So sometimes we have to put an oral airway, we just slip it in, and it kind of keeps the tongue down and open and back, and also keeps suction, because if you can't control that, then you're going to have trouble swallowing your own spittle or anything else. So we'd want suction connected so that you can suction and clear the mouth. Warm blankets, of course, because they have been cooled down. The OR is very cool to hopefully decrease microorganisms. And because of that, the patient gets super cold. Their body temperature goes down also. And so we want to warm them back up, because shivering, just so you know, if you are cold and shivering, you are using a lot of energy to shiver. It is not a good thing. Shivering is not a good thing. We don't want people to shiver. So you want to warm them up to prevent shivering, because the more energy used, the more oxygen's used. The more oxygen's used, you see, it's all connected. So warm blankets, warm them back up to a normal temp. Get vital signs, of course, immediately, and you're going to monitor vital signs. So if they come back to you to the floor, you're going to want to check your vital signs frequently. Q15 times 4, and let me find it specifically for you so you know exactly what it is. And then you go Q30 times 2, and then Q1 hour. And I will find that and specifically tell you that again here in just a few minutes. But you want to take vital signs on a regular, frequent, and then when you know that they're stabilized, then you can, it's a time frame so that they're clear. A neurological assessment. We want to check their neurostatus. When they are put under, everything goes to sleep. People stroke under anesthesia. They can have small strokes and stuff. And until you wake them up, you don't know. And so we want to make sure also neurologically that they're intact, so that they can maintain an airway, wake up, and be able to swallow and do all the things that they should do. That neurological assessment will include level of consciousness, orientation, are they oriented to what's going on around them? Sensory and motor status, can they feel you touching them? Are they able to move on command? And then pupils, are they equal in size? Are they reactive? We need to know that. They're going to wake up sleepy and drowsy, but are they arousable and awake? If you have a patient that you arouse, they awaken, and they're like, and they immediately go back to sleep, do you think they're going to be able to breathe or do what they need? So arousable and awakening is you want them to be able to come around and keep their eyes open and communicate and obey commands. Those are the things that we need and want, so that we know that they're neurologically intact, so that we can move forward in the recovery piece. Intake and output. You don't give anything back to them. Ice chips, um, clear liquid. Start slow always with a patient that's had a procedure done. And you start with ice chips first, just a couple ice chips, and then clear liquids. Because the medicines that have been given, the anesthesia and some of the pain medicines, can cause nausea and vomiting. And you don't want them to get sick on their stomach. But prior to even ice chips, you need to make sure that they have gastric movement, that their bowels, you can hear bowel sounds. We need to hear a tinkle. Now, they might be hypoactive because they're still trying to awaken, but if you can hear a little tinkle, even hypoactive, they can probably tolerate ice chips at that point. But always make sure that you have an emesis basin or one of those tubs, like I said in the previous slideshow presentation, or the suction ready so that if they get sick, they can catch it or suction themselves out, or you can for them. Always check your IV lines. We want to make sure that they're patent, and that their fluids are infusing without any difficulty. Also, Foley catheters, if they have one in, that's the output piece. You want to make sure that it's not kinked, that it's flowing without any issues, because the patient at first will not have the urge to go. They're not going to be able to tell you. The other thing is if say they don't have a Foley catheter, then you want to make sure that they're going to urinate. And then of course, before they go home, we usually want to make sure they've had a bowel movement, or at least they have passing gas is a good thing. And then the dressing. So whatever dressing is put over that, we need to make sure that we're assessing that. If there's blood, anything like that, if you can see any kind of drainage on the dressing, you would want to take a Sharpie and outline that so you can watch it to make sure it's not getting worse, because it could be just the initial. The other thing is we never remove surgical dressings, not the first dressing. The surgeon will do so. So we have Aldrich scoring. This is what happens in PACU. This is how they score the patient to see if the patient is ready to be transferred back to the floor. It's kind of phase 2 of the surgical patient. They're getting ready. We're going to score them. There's 5 categories that we score them in. Activity. Is the patient able to move their extremities on command? They need to be able to do so. Can they breathe on their own? Number 2. Do they have a blood pressure that is conducive to homeostasis, that's within norms? Are they consciousness? What is the level of their consciousness? Are they awake? Oxygen saturation, the patient's oxygen saturation level is within a normal. So they're breathing on their own, they're oxygenating, they have a blood pressure, and that states that they have proper circulation. Are they awakening? That's the neurological piece, making sure everything's intact before they take them up to the floor. Now, they're going to go ahead and be sleepy for you because that's just part of it. And there is a demand on the body when it is put under surgery, or as it goes through surgery. So it's like working out really hard. So they're going to be tired. Discharge criteria depending on the patient condition. And then same day surgery, just so you know, it takes 1 to 3 hours. So if it's a same day surgical patient, depending on what's going on, if they have renal insufficiency, if they have kidney disease, or they have end-stage renal failure, they're on dialysis, anything like that, medicines do not filter through appropriately or properly. And because of that, they hold on to those medicines, and the medicines will circulate through the body. So they take a little longer to recover from anesthesia, from pain medications, things like that, because they're going to stay in the body. And you need to think about that. That's why your medical history on your patient is so vitally important. They might be in to have an arm fracture repair, which has nothing to do with their kidneys. But if they have a history of renal disease, then you need to be concerned about how they'll metabolize their medicines. If they have a history of liver disease, then you need to be concerned about their bleeding. Do you see what I'm trying to say? If they've had a history of stroke, they're more susceptible to stroke, or they'll have some neurological deficit. If that's the case, then you need to be concerned that they're not going to wake up, or how they wake up from anesthesia. And then the other thing is always with a surgical patient is if you get them before surgery, or that pre-op piece is asking them if they've ever had surgeries before, and if they had, how did they do with anesthesia? Because we need to know. Some people wake up Fruit Loop. They are all over the place and can't, and it takes them a long time. Some of them wake up sleepy. I will tell you personally, I'm a person that I have trouble coming out of anesthesia. So you'll hear the nurse say to me, take a breath, because I just don't breathe. I just lay there. And I kind of arouse, and I'll take a big deep breath. So it just takes me a little bit. It really hits me hard. So those are things to think about. So you are only as good as your assessment. So let's talk about it. Airway, ABCs, airway. We're going to look at lung sounds, depth and quality of the air movement. You want to listen to the lungs, look at your rate, and stimulate your patient to wake up, to breathe, and see how they're doing. Also monitor, because the vital signs will tell you much. If they're not taking a breath, their SAT will go down. The respiratory rate will be down when they're in that sleepy, kind of groggy stage. But arouse them to have them take deep breaths, but also assess their sounds, depth, quality of air movement, and their rate. Also, their oxygen saturation, they should be watched. Their SATs should be watched at all times. And if they're on oxygen, what is the rate ordered and the patency of the system? So you want to know, are they on a nasal cannula? Are they on a mask? And what are we doing? If they are still intubated, then we would want to know the ventilator settings. And we'll learn about vents next semester. So, but for now, I want you to auscultate those lungs, count that respiratory rate, arouse them, have them take deep breaths with you as you're listening so you can hear. And then also too, oxygen saturation should be continuous at this point. Circulation, you want to listen to the heart, check your peripheral pulses. And if there is surgery on a limb, like say the right leg, then we definitely want to know, do we have a pulse below the incision or the surgical site? Anywhere there is an injury or surgery on an extremity, you always want to check the pulse distal, make note of this, and you want to compare it to the other extremity. So if I have my right upper arm worked on, I want to make sure my right radial pulse, I have one, and it's good. And then I want to compare it to my good arm, my left arm, to make sure that they are comparable. They should be close. Sometimes they might be a little bit less, but that's just natural. But you should have it, it should be close. There should be no anything impending or causing decreased circulation. The vital signs need to be checked every 15 minutes for 1 hour. Put this in your notes. Here it is. Every 15 minutes for 1 hour, every 30 minutes times 4, every hour times 4, and then every 4 hours, 24 to 48 hours after surgery. And that 24 to 48 is your agency protocol. But every patient coming out, I don't care who, Q15 times 1 hour, Q30 times 4, and 1 hour every 4, and every 4 hours, every 24 to 48 hours after. I kind of bodged that up. Let me say it again. 15 times 1, 30 minutes times 4, 1 hour times 4, and 4 hours every 24 to 48. And just remember, it's up to your protocol. Fluid status and hydration. Let's see, that's your IV's infusion and your flow rate. Make sure what is ordered is going, what the fluids are. Sometimes they'll give fluids in the OR, but the doctor has ordered different fluids to be given in the post-op piece. So make sure you check your orders, make sure you look at your IV bags, and make sure that what's going is correct. They might be giving mass fluids in the OR, but post-op, we're not giving mass fluids. We need to have whatever the doctor has ordered. So that is something you want to check. You also want to make sure that your IV site is good. And you want to always make sure that you have more than one IV site, because you need an IV site to give your fluids and your medicines. Some of them are compatible, some of them not. And you always want access in case there's an emergency. So you have one IV that can be giving stuff and one that if you needed to, you could break it down and use it as your emergency line if needed. Also look at your intake and output. And your skin turgor, and your oral membranes. We want to be looking to make sure they're getting plenty of fluid because they're not taking it in at this point. And we need to also make sure what's coming out. You want to measure everything. This isn't the time to be, guesstimating. We want to know, are they urinating adequately? They need to have at least 30 mLs an hour or 60 mLs every 2 hours. Do the math, same thing. So sometimes questions are worded a little differently, but you need to understand that. So looking at the fluid status and hydration, those are the ways we're going to look and see if you have moist oral membranes. It's another way to see if they're pale, is looking at their mucosa, oral. Surgical site, you want to check for bleeding, mark boundaries of drainage on the dressing. Like I said, with your Sharpie, go around it, assess wound drainage in the container. So if you have a drain where it's collecting, you need to be measuring that. We need to know. You want to keep, if it's a JP bulb drain and it's full, you'll need to empty it, measure it, and make sure that it's discharged, meaning you squeeze it down, cap it back up, and it'll slowly expand, pulling the drainage out into that container. That's what they do. They look like grenades. You'll hear them called grenades sometimes. Different drains, if you're not sure what they are, make sure you look them up. If you're the nurse receiving them, make sure they're patent, though. That's the main thing, that it's draining if it's supposed to be draining, and what is it draining. If it's blood, pure blood, that might be not good, a big red flag, and you'd want to call the surgeon. Any issue with a drain, you don't pull them out, you don't put them in. If it's partially out, you don't push it back in a little bit. And any nurse that's doing that, shame on them. You need to immediately just cover the site and call the surgeon. They need to come up and fix it, because infection is something we do not want. Gastrointestinal, this is a huge one because of anesthesia. Anesthesia makes everything go to sleep. And then even if they're not getting general anesthesia, but they're getting moderate sedation, those medicines make them very, very sleepy. Now, it should not make their stomachs go to sleep, but it can cause nausea and vomiting. So we want to make sure everything is awake and working like it should. So you're going to auscultate your bowel sounds. You want to assess the abdomen and check if they have an NG tube for the drainage, the color, the character, and the amount. And also make sure it's patent. This is so important. Also, any tubes going to these patients, you want to make sure that they're patent. But bowel sounds, if they do not have bowel sounds, if you have someone, I don't care if they're just sick with something GI, if their bowels are not moving, if they have a blockage or anything, whatever is going on, no bowel sounds, the patient will throw up. It is part of how our GI tract works. You have to eat, drink, whatever. Bowel sounds are there, peristalsis takes place, and that whole digestive process starts and finishes. If you have no peristalsis, then you're going to have nausea and vomiting. So what do? NPO, keep the patient NPO till we have bowel sounds, and also maybe give them medicines to help with nausea, because we don't want them throwing up. It causes a lot of stress and strain on the body. All your tubes, like I said, they need to be patent. Make sure that they're not tucked up under the patient and everything's where it should be and draining like it should. Kidney function. You would want to check your labs prior to your patient coming back, looking at their creatinine, looking at their BUN, making sure that they're normal. If not, also kidney function, making sure they're making urine, and we talked about it. Um, Check your output, of course, measure it from your Foley catheter if they have one. If they do not have one, they have to void. Put this in your notes and highlight it. They have to void within 8 hours if there's no catheter in place. So your patient gets back to you. If they don't urinate within 8 hours, then you need to be calling someone because there's a problem. If they check, also assess are they distended, because you can tell if a bladder's distended, means it's full and they can't urinate. It's also painful, or they have the urge to go but they haven't gone. There's things to be concerned about, so remember those things, and just know 8 hours is the magic number. You can also do what? You could bladder scan them and see if they've got urine in there. Sometimes they've emptied their their bladder prior to surgery, and they've had a little bit of fluids during the surgery, not a lot, and they come out, they haven't had anything to drink or eat, and so they don't have enough yet to really have to get the urgency to go. 8 hours is the magic time frame. Okay. Skin, pressure areas of the body. Make sure you're turning your patient every 2 hours. You can help splint the incision if it's very painful for them as you turn them. They need to make sure they don't hold their breath when you turn them. Have them breathe in and out through their mouth. Instruct them. But turn them and prop them with pillows, support them with pillows, and get them on their side. This is going to do several things. It's going to prevent skin breakdown, but it's also going to help prevent post-op pneumonia or hypostatic pneumonia. And because of that, movement is important. That's why when they can get up, they need to get up and start walking. If they can't walk or don't walk, then they need to be up in a chair. But upright is what we want down the road. Safety. Make sure everything is intact, the equipment, and is functioning properly. And also remember your side rails, bed in low position. Also, always reminding and reinforcing that do not get up without assistance. Those things. Call bell is in reach. Going back over how to use the call bell. It's difficult. You've gone into a la land of anesthesia or surgery or a procedure, and you've come out of that and you can be confused and trying to be clear, you can almost like a dreamlike state. So you want to make sure that they're clear enough and that you reinforce it. Check on them. If they're at risk for fall or unable to use call bell, or you're not really sure they're going to be compliant with that, there are alarms. Set your bed alarms, set your chair alarms if they're already up in a chair, as you go along. But make sure you are keeping your patients safe. That's a biggie. So post-op vital signs are vital. You need close vigilance, as they say in this early post-op period. We want to know, you want to know as the nurse, because vital signs speak to you. They tell you much. If a heart rate is fast, it can be pain, it can be bleeding, it can be a volume issue. Also, it can be a reaction to something. If your respiratory rate, if you're tachypnic, it can alarm you to things. Blood pressure, if it's high, it can be pain, different issues going on. If it's low, we could have a volume loss. We're losing volume. So you want your vital signs to be monitored, and you don't want to actually put a CNA or an unlicensed person with them taking vitals. You really should do it yourself. And if you do utilize a certified nursing assistant to get your vital signs, make sure they're reporting them directly to you so that you're aware of what's going on. Don't ever not be aware. Um, This can tell us if there's having various surgical complications. So vital signs are important. The first 72 hours after surgery require frequent observations to detect signs of post-op complications. So even though we do surgeries quickly, guys, I mean, more or less, they did my mom's hip replacement same day. Whole hip replaced, and she went in at 7:30 in the morning and she was home by 3 in the afternoon. So we have really progressed with getting people in and getting people out. But that's why it's so important that we teach family and the patient and family what to expect, what they need to do. And it's hard. I mean, I'm a nurse, been a nurse for a long time. My sister's a nurse. And, I ended up having to go down there. My sister had her at the first part of the week, and then there were some issues going on. I went down there, the two of us, and I mean, we had to still ask questions and we're still concerned. We had enough sense to do other things because we've been out there in the world, but definitely 72 hours, a lot of things can go awry. And let me just make sure I don't want to add anything else to that. Um, and as we go along in this, we'll talk about some things that can go awry. So just hold on because it just keeps on keeping on. The thing you need to understand is anesthesia can cause the nausea and vomiting, and so we worry about that. So we don't want them to have that, and it's vitally important because if they do, it can cause stress on the incision and sutures if they throw up. So always know that we can do some things without even giving meds. Also, if somebody's nauseated and vomiting, do you want to give them something by mouth? No, that's a no, because they're already feeling like they're going to throw up. You put something down into the stomach, they'll probably will throw up. So that's where we can use suppositories or we can give meds IV, depending on what's going on with this patient. The other thing that I want you to understand is that we can have spinal anesthesia. So after that, we want to keep IV fluids running as ordered. You want to lay them flat for 6 to 8 hours on spinals. They can feel like pins and needles. Keep them flat, keep IV fluids running, and encourage them to increase fluid intake if they can, if they have bowel sounds present and can, without getting sick. And also caffeine, because just so you know, caffeine will raise the vascular pressure of the spinal puncture site. So if they go in and puncture in to do this anesthesia, by drinking caffeine, it can help seal that, which I find kind of interesting. I want you to know I didn't really know that. So oxygenation and ventilation. ABC, we need to be ventilating. You want to maintain a patent airway. It's the priority measure to promote oxygen and ventilation. We have to do it. If you watch your oxygen saturation closely, and if needed, we can add oxygen. Sometimes you can call, the surgeon will have parameters, and you can start, nasal cannula 2, 3 liters, 4 liters, up to 5, and then we go to a mask. But anytime you're having to up or increase oxygen, you need to be in contact with your physician because you might have standing orders for that, but if I go from 2 to 4 and I'm still not oxygenating well, I need to be calling the doctor, the surgeon, and telling him. Even if he's in another surgery, he has people that have his pager. He can answer. Remember, ventilation is the movement of the gases. That's where we move. That's where the CO2 and the O2. So sometimes we can put them on an end-tidal CO2 monitor, and that will let us know if we're actually exchanging the gas, if those things are happening. And we're seeing that more and more. Lots of times when I was a flight nurse, if they were intubated, we put the end-tidal CO2 on them because we wanted to know what their CO2 was more than we wanted to know. We could monitor their ventilation that way much better and closely. So it's something that you might see down the road, just so you know what that is. Anesthesia, once again, it makes the lungs go to sleep. So all the alveoli, they collapse down. That's why we ventilate a patient, That's why they have to be intubated and put on a ventilator. We put them on, and it's going to give them their breath. It's going to breathe for them. But what happens is it causes and creates the alveoli to become sticky and collapsed. And that's why people, if once they're out of surgery, they have to deep breathe, cough, and do incentive spirometry. Vitally important. They also don't move during surgery. Think about it. If you are in open heart surgery, you're in for 4 hours, 3 to 4 hours, depending. And so your chest is opened up. You lay in that flat position. Arms are out to your side for that long with no movement. Have you ever laid in the bed in one position for a long period of time? Like really not moved at all? It hurts after a while. So can you imagine? It also will cause problems with oxygenating ventilation because we're not moving and movement is needed. Limited mobility in the immediate post-op period. We need to get people moving if they can. We get them up. We get them up. We sit them up. When they can move, then we need to move them to prevent them from getting hypostatic pneumonia. So what happens is when those lungs collapse down, those alveoli, it's atelectasis is the term. And so that is the collapse of the alveoli in the lungs. When that happens, it happens after anesthesia, and they can become hypoxic from this. So they all have most patients come back with a little bit of atelectasis. So that's why we need to make sure they deep breathe to pop those alveoli open, cough, bring any kind of yuck up, and be doing that incentive spirometry, because that's when you suck in on it, like I said before, then it pops open the alveoli, and that's what we need. Those things are so vitally important. If a patient is unable to get up and move, we need to be turning them every 2 hours, no less, or no more. Don't let them go any longer than that. We need at least every 2 hours. If you can, if they are uncomfortable and you can move them in prop pillows, do so. We like a patient to rest though. So you want them to be awake, but you want them to rest too, because the stress of the body on the body from the surgery. So about every 2 hours is a good time to go in and do everything you need to do, including turning the patient and supporting them with pillows. Also, if you need to, go ahead and if they need oxygen, you would apply oxygen as ordered. Remember, oxygen is a medicine. It's not something we decide. There are a lot of protocols out there. So when you start to work as a nurse, you need to understand and know your protocols. You don't make that decision on your own. You don't go, I'm going to give 5 liters. I'm going to start this mask. No, if there's a protocol, you can. But I will tell you, usually 2 to 3 liters or 4 of oxygen is okay. You can get that started as you're calling the doctor. If your patient is under duress and you're worried that if they're going to have a respiratory arrest, if you're worried about them stopping breathing, if their SATs dropping slowly, you can't wait to page the doctor and the doctor call you back. You will be putting oxygen on as you're calling the doctor, as someone else is calling the doctor. You want to intervene. So, but just remember, bottom line, you have to have an order for oxygen. So we're into circulation, the C piece, right? Maintain circulation and tissue perfusion. Blood transfusion, including auto transfusion. Sometimes if their hemoglobin, if they've had a massive loss of blood, the hemoglobin and hematocrit have dropped. If that's the case, there might be an order. They might have gotten blood in the OR. You need to know that. You also need to know if they got an auto transfusion, either or. Volume was lost and volume was given back. We need to know that. Also, post-op, if we are going to be watching for bleeding, and so we will want a CBC lab to be ordered. And usually doctors will, if not right after surgery, they'll get it the next morning or that evening. But you want to make sure as the nurse that you're looking at that. Also looking at their pre-labs, looking prior to surgery what their H&H looked like before going in. They could have had a low one going in and then be given 2 units and come out and look great. They fixed the problem. 2 units were given in the OR and they're looking good. But you want to watch those things. We also, antithrombosis, we want to look what's thrombose, what's a thrombosis. We're looking at clots, sequential pneumatic compression devices. We want to prevent the patient from having any kind of blood clots in their legs, in their lungs, PEs, those are pulmonary embolus. We need to prevent all of that. And how do we do it? We put those sequential SCDs on, sequential pneumatic compression devices. We can give different medicines, heparin, Lovenox, which is a low weight subcutaneous heparin. That's what Lovenox is. We do all of these things, walking the patient, all of that to prevent them from having blood pool while they're laying there for long periods of time, because that's what can happen during surgery. And post-op. And so we want to get that and prevent them from having those. A lot of people can die from pulmonary embolus. They can have major post-op complications from clotting issues. So those are the things that we need to do to prevent that. Your blood pressures, when we're looking at blood pressure, we want to look at what their blood pressure is and look at what their blood pressure is prior. You can't go look at a blood pressure and go, well, wonder what you want to know what their normal blood pressure is. If you are working in a doctor's office or you are a patient going to the doctor's office and they take your blood pressure, I always say, what did it read? Sometimes they don't tell you. And I'm like, well, what was my blood pressure? And they'll tell me, oh yeah, that's about right. That's where I live. But if it were high, I'd say that's high for me. They would not know that. And so it's so important that we compare. You know how we say trending? You want to trend vital signs, things like that. You also want to look and compare things. What were they prior to surgery, and what are they now? And we should, because people usually need to get back to where they were or better, but not worse. Heparin, remember Lovenox, we give those at sub-Q. We give them in the love handles. Make sure if you're giving Lovenox, you're doing it correctly. 90 degrees in, making sure that it has an air bubble in those syringes for a purpose. It goes in and that little air bubble follows behind it to seal it so it doesn't go into other areas that it should not. Just 1 second. If they have a history of thrombophlebitis, which is a clot and inflammation of blood vessels, they're at a higher risk for thrombosis. They are at higher risk for clots. So we want to make sure that we are doing those things. SCDs, make sure the physician is going to give them Lovenox or heparin. Those are the reason why you're giving these. We're trying to prevent stuff. Any extremity, remember, I want you to always check the distal pulse wherever. If you have a broken bone in an extremity, any injury to an extremity, or any surgery to an extremity, always you should be feeling below. Do they have a pulse? If we don't have a pulse, what do we know? Tissue's going to die. So we're trying to do all of the things, walking them, doing all this stuff to prevent them from getting blood clots. It's so vitally important. So, of course, prevent injury. This is the spinal anesthesia. I've already talked about it in the earlier slide, but they can be numb and heavy in their legs, depending if they have a block or something. Keep flat for 6 to 8 hours until the feeling returns. The patient is susceptible to hypotension until the spinal anesthesia effects are gone. So they're going to be hypotensive, so we'll need to support their it's possible they could be hypotensive. If that's the case, we would need to support their blood pressure with medicines, different IVs, medications that can help support them. But we want to monitor them continuously on their blood pressure, right? You would take their blood pressures frequently to know that they're okay. Keep the IV infusing as ordered. Fluids are important because that's what's going to help maintain that blood pressure. And fluid intake, and I talked about that. They can drink through a straw, and also make sure that they are, because they're laying flat. You got to remember that it's not easy. Have you ever tried to drink something out of a glass without a straw laying flat? Very difficult. Some people are very coordinated, some aren't. I'm not. The other thing is caffeine will help seal where they've gone in for the spinal anesthesia. So we like caffeine in this situation, definitely. It also helps, increase heart rate, which will help help with the blood pressure too, if you think about it. Kind of as a catch-22. Effective surgical positioning and pressure points. Just make sure you're supporting things with pillows. We don't want breakdown. It hurts. If you have a really bony hiney and you lay flat for a very long period of time, it's going to break down. There's no tissue there. Elbows. Anywhere it's bony prominence, you should worry about it. Heels. Float those heels, guys. Don't put them on top. Don't put the feet on top of a pillow. Put the pillow behind the ankle there and the calf, and let the foot, the heel, hang over the edge of that. It's called floating their heels. Very, very important. Back to fluid balance and elimination. I've said a lot of this. I'll repeat some of it. Remember, the normal is 30 milliliters an hour. If the flow is less than 60 milliliters over a 2-hour period, the surgeon must be notified. So you need 30 an hour, but the magic number for this post-op surgical patient is 60, less than 60 in 2 hours. So you might have less than 30, but then it starts to pick up. So that's what they're saying. If it's less than in 2 hours 60, you need to call the surgeon. But remember, 30 an hour is our normal, and that's what we need to be at a normal fluid balance. Our kidneys are functioning and working. They must void within 4 to 8 hours, depending on the type of the surgery. 8 hours is the ticket if they have not, but you should be assessing that. You have bladder scanners. You can palpate the bladder. You can, ask the patient, do they have the urge to go, or are they hurting, or sometimes people just don't realize it. You turn on a little water and you remind them, and all of a sudden, whew, yeah, I do need to go. Or put them on, the bedpan because they can't get up, if that's what they need, or urinal. Nausea and vomiting, once again, we want to prevent aspiration. How do you do that? If you're having to lay flat, you can't sit them up, right? So what do? We can do a reverse Trendelenburg. Trendelenburg is where you're flat and the head goes down. This is where you're flat and the head just kind of, you tilt the feet down. They're not going to fall out of bed, I promise. You can tell them that. Make sure there's a footboard on your bed. In case they slide a little bit, they have that, but they don't fall out of the bed that way. You can use a cool cloth, of course, around the neck, front of the neck, back of the neck, forehead. You can give them oral care because their mouth is dry, or they've been, intubated. It's got a horrible taste, or medicines that have been given IV. Sometimes people can taste it. There's a metallic taste. Give oral care that can help sometimes with nausea. Quiet environment. Turn the lights down or off. They don't need 700 family members over the top of them, or crying, or any of that, or the phones ringing, that kind of stuff. All of that, quiet environment. And free from odors, because I don't know about you, but there's certain smells that make people sick. That's why it's so vitally important as a nurse, you do not smoke in your uniform, because people who get sick off of cigarette smoke, they can smell it. And if they're non-smokers, they can smell it a mile away. My mom's a non-smoker. She could smell smoke a mile away. It gives me a bad headache. So it's a smell that is not very good. And you don't want your patients to smell that. It can make them sick. The other odor is perfumes. Don't be perfuming it up from top to bottom, because it can actually trigger nausea and vomiting in your patient. But then also in the room, don't be spraying things, that kind of stuff. If you have a family member that's wearing really heavy perfume, the patient's nauseated, and they say, I can smell your perfume, you might just explain to them very nicely that perfumes can set people up from being sick. Do you mind stepping away from the bed or even out of the room if needed? If it's about the patient, it's about the patient, not the family. Ice chips help cold when they're able to take clear liquids or you feel they have hypoactive bowel sounds and stuff. Popsicles are a good one. People like to nibble on popsicles. They're cold, they're kind of sweet, and fruity taste. People love it. Some people come out of surgery and they're like, I'm ready to eat a steak dinner. And I'm like, well, guess what? It's less jello. I can cut it to look like a steak. You're not getting the steak until I know you can tolerate a steak. So you want to start them slow. Just start slow. Ginger ale, Sprite, 7-Ups, the clear liquids, then go, and jello, popsicles, those things. Once they have like hypoactive bowel sounds, you can start that way. Even bowel sounds, start them slow. If they can eat jellos and everything and there's no throwing up or anything, then you can advance them into whatever their diet is supposed to be post-op. Most patients go back to their normal diet after surgery once everything is post-op is over and they are able to tolerate clear liquids, and then you go from clear liquids to not clear liquids. You can full liquids, so you can do milks and stuff like that if they want, pudding, stuff like that, to see if they can tolerate. So on this slide, I pretty much have said everything you can. Give stool softeners to help along with the bowel movement piece, supplemental nutrition and enteral and parenteral nutrition. We can give shakes, things like that if we need to. Worst case scenario, if they can't take things into the gut, we can do it in other routes to give the nutrition that they need. They need bowel sounds in all 4 quadrants. After the bowel sounds are heard, of course, I've already gone through that. They can have clear liquids followed by full liquids and then a regular diet if the preceding diets have been tolerated. After the patient's eating, though, and I want to make a note of this because I haven't said this, is after they're eating again, a bowel movement should occur within 2 to 3 days. A lot of people are very fixated and very scared that they're not going to have that bowel movement. So it's so important that you're watching it and explain to them. Sometimes it takes 2 to 3 days before you'll have a bowel movement. We're giving you the stool softener. You've got great bowel sounds. We'll get there. And sometimes taking them and sitting them on the toilet helps too. So, and allow them to sit, like not just sit down and nothing happens then we're up, but sit for a few minutes and allow gravity to try to start helping things to take place. So flatus or gas, right? Discomfort from the abdominal distension, and considerable flatus may occur after general anesthesia because of peristalsis ceases. So when the anesthesia is given, everything slows down or stops. Excuse me. And by saying that, what happens is when peristalsis, that's what gives us our bowel sounds, the little tinkling of the gut, it's moving things along. When that ceases, gas can be produced, and because of that it can become very uncomfortable. If people have not had trapped gas before, it can take a grown man to the floor. That's how painful it can become. So we need to understand that it can really be bothersome. They need to take small amounts of liquid or food at a time. Drink tepid liquids, not something super cold, super hot. Tepid, that's room temperature, kind of warm. And refrain from drinking from a straw because that'll help keep the flatus to a minimum. Now, once again, hard, isn't it? Some people can, some people can't, depending. In this situation, if they're having discomfort from abdominal distension and a lot of gas from being put under anesthesia in their surgical procedure, then you want to follow this. So no straw. So you'll have to do the best that you can. They can drink kind of out of the side of their mouth if they need to. But sips, nothing major. I've even taken syringes and pulled up a little bit of their fluid because you're not getting tons of it. They're not chugging a drink, but small amounts of liquid and just kind of putting it into the side of their cheek and letting them get it that way. Ambulating helps move and evacuate gas. tell them better out than in, because they're going to pass gas and be embarrassed, all that kind of stuff. Let it out. If not, it's going to cause them pain and discomfort, and we do not want that. Also, if permitted, it says a slight Trendelenburg's position may assist in evacuation of flatus. And I'm just going to go on record with this. Trendelenburg's position is there. We still use it somewhat in the critical care, because if you lower a head, it's going to increase blood pressure. That's why we do it. But when you lower a head slightly, you will cause blood flow to increase, and you can cause an increased cranial pressure. So they really frown upon Trendelenburg's position anymore, but that is here. It's part of it, and I just wanted to share that with you. I would stay away from it, though, unless you're really comfortable doing it. So promote comfort. Of course, we want comfort for these patients. The goal of comfort management is to allow the patient to perform levels of activity. What they can do, it's going to help. Non-pharmacological measures, pillows, splinting, incisions when coughing, deep breathing, different things like that. What is it? We can lower the lights for comfort, cool the room down if they're hot, if they're cold, warm blankets. There's different things we can do to help make them more comfortable and feel good, and it promotes healing. We want to promote rest if we can. That is so very important. Keeping them warm if they're cold. Nobody wants to be cold. We also making sure their dressings on the extremities could be checked to make sure they're not too tight. We would check for a pulse and skin temperature sensation. They should not have tingling, anything like that. If so, it needs to probably be loosened. You should be able to slip your little finger under a dressing and the extremity. Dressings that are too tight cause pain. Just know that. So you want to check it. Make sure your fingers can go up under it. It should be able to. Hiccups are huge. They occur after surgery, making the patient quite uncomfortable. It's a spasm of the diaphragm, and so it's having a spasm. Have the patient breathe into a paper bag will often relieve hiccups. Sedatives and tranquilizers are sometimes prescribed to promote relaxation and reduce irritation of that phrenic nerve, because that's what causes them. Severe persistent cases of hiccups may require surgical interruption, and that's later if they keep having them. And it's to remove the nerve pathways to remove the cause of the spasms of the diaphragm, and that's what they do. But most of the time, people will have hiccups. They can breathe deeply into the paper bag 20 times. That can help. Stick a finger in each ear and hold your breath. These are remedies we've done and people say work. Drink from a glass that someone else is holding for you. I've never done that one. Place a teaspoon of sugar or peanut butter on the tongue and let it slowly dissolve. Acupuncture and hypnosis. These are different kind of alternative therapies to stop the hiccups, but you definitely want to try. And the bag and the deep breathing, it's controlling. Different things can create these issues. So non-pharmacological measures are huge, guys. This is where, as the nurse, you can do this all day long. You don't need a doctor's order. Rest, turn, cough, deep breathe frequently, reposition the patient. Be sure the bladder's not distended and causing discomfort. That's your assessment piece. If it is, then you call the doctor at that point and get an order. Do a bladder scan, see how much urine's in there. You can do that without an order. Check the patient if the patient's warm enough. If they're cold, get a warm blanket. There's warming blankets, blanket warmers throughout the hospitals. If you don't have one where you are, you can probably get one from somewhere, but get them warm. Use distraction and imagery. Definitely, relax, close your eyes. Where do you want to go? Think of a wonderful place. Go there. It does work, guys. It helps. If you haven't done it for yourself, try. It's a good thing to calm yourself. Slow, deep breathing as you're thinking about being on that beach or wherever you want to be at the top of the mountain. Teach relaxation techniques. That's those different things. We can use oils. They can be put on cloths for them. Aromatherapy is a big one nowadays. A lot of different just relaxation, and they're there of how to just slowly let things go, slowly close your eyes. Lord, we'll both all be asleep here in about a minute. And then of course warming. We like to be warm. Nobody wants to be cold. And warm the patient. Also remember that if they have a surgery that is causing a breast removed or something like that, they're going to have emotional pieces, things that body image issues. Just having a big scar down the center of your sternum or down across your stomach, things like that, it can be very harming to patients. So we need to make sure that they're able to talk about it, that they're, let them express their fears. Don't disregard their fears, acknowledge them, and then explain to them how, things work, and these are processes, and there's support groups. If you need to get counseling involved, call the social worker and call those and get the doctor to order for people to come in and help with this. There's people there to help with all of the different things. You need to understand that it's not for the nurse to fix it all, but it is for the nurse to know who to contact to get the support that's needed to help fix it all. And that's what helps. So medications, they should be given consistently for the first 24 to 48 hours post-op. We're looking at pain meds. Assess pain level and effectiveness of the analgesia using pain scale at least every 3 hours. We're not doing this once a shift. We're doing it frequently, and we need to. For the first 24 to 48 hours post-op, every 3 hours, we're checking them for pain and discomfort, putting it on a pain scale, and then going from there. If they're unable to get medications, then we go the non-pharmacological way, right? We want to go that direction. If they can, then we can give them their pain medicine. We need to make sure it's on a pain scale, and we reassess that pain. Now, also remember that pain medicines do a couple things. They're going to constipate the patient. So we want to make sure that we tell them that these can cause constipation, but we're giving you stool softeners, and also, increase if they're able to take warm liquids, increase that to help with peristalsis, to keep things moving. We want to keep things moving. Remind the patient to request medications before the pain becomes severe. If you have a pain of 4 out of 10, and you give a pain pill, you're probably going to get the pain controlled down to maybe nothing, or at least a 1, right? Definitely down low. If I have pain at 10 and I gave a pain pill, it takes a lot longer to get it down. It might drop it to an 8 or a 9, but is an 8 or a 9 good? No, they're still in a ton of pain. So it's so important that patients understand that they need to let you know that they're starting to hurt, so that you can medicate them and they can continue to deep breathe, cough, incentive spirometry, get up and walk if necessary, and hopefully move and stuff so that they can go to the bathroom, breathe on their own, and do well. But pain has to be controlled. It's not something that we just bite a stick and piece of leather and hope for the best. We don't have to anymore. We control it. So opioids, people are fearful of them. They should be. They're highly addictive, but they're great pain medicine control. They help control pain, but they can depress respirations and the cough reflex. So if you already have a patient that has depressed respirations or isn't breathing very well, do you want to give them an opioid? Probably not, because you're just going to make it worse. So what you want to do is maybe give them something that is not a narcotic for pain that will help. NSAIDs can cause more bleeding, so we have to be very careful. It's not ibuprofen time. It's not a time for NSAIDs, but we can look a different level or maybe a lower dose with a combination of something to help give them better control of pain with less side effects. So, pain medicine is big, and it's something that's controversial anymore, but people that hurt need it. Now, you will occasionally have someone who has either been addicted to drugs and concerned about it, and they don't want to take the opioid, and if that's the case, the doctor will order something else, and you need to respect that, because I respect that. I think you know what you can and cannot have. Um, Nobody wants to be addicted to pain pills. It's a bad scene all around. The other thing is we can do, used to we gave Demerol and Phenergan, and they've gone away from it. But just so you know, there are medications that potentiate other pain medicines. So we give those. It means they make them better. They make it a better high or a better release or relief. So when you do a combination of those, you get a better outcome, and you use less of the narcotic piece, and with the combination you get better control of the pain. Okay. So we want to promote rest and activity. We want to promote sleep. They need to. I won't lie to you. If you're in the hospital, you're going to get vital signs checked. You're constantly being poked and prodded. It's hard to rest. We have to do our job, and there's a reason behind it. One of the things I found in Nursing 101 is students didn't want to go wake their patient up if they were resting. But we have to assess, because are they resting because they're having a stroke? Are they resting because they're over medicated? Are they resting because they can't neurologically, something's going on that we're not aware of? Things like that. So we waken them. You need to make sure that you're assessing properly. But when they can sleep, let them sleep. Range of motion and ambulation. We need to, let's get moving. That is so vitally important. When we have surgeries, if we are elderly, even middle midlife, but elderly patients especially, they can be deconditioned very quickly. So if they lay in a bed for a week, they're going to have a hard time moving. So we need to make sure that they're getting up and moving and ambulating accordingly so that they can build back up to where they were. The longer they don't, they become deconditioned, and it's harder to get it back. We also want to prevent any clots. That's why it's important to get up and get moving. Embolisms are not our friend. Physical therapy can be ordered and is a good thing. If you have a total hip, you want physical therapy to get in and teach you how to use the walker, how to get up, how to get around, exercises to do to build, how not to hurt the incision or the repair, and get back to a baseline health. And then family involvement. And nowadays, the family needs to be involved. As the nurse, if they have family that can be there, let them be a part of the teaching, let them be a part of the care when they're getting ready to go home. If it's learning how to do ostomies, the family needs to be there. Schedule it. We're going to do a change the site in the bag, the wafer and the bag. And when we do that, we're going to do it at 11. Can you be here? They go, yes, great. You're the one that's going to be home, and you're the one that's going to have to help this patient through this. So family involvement is huge. Don't push the family out because you don't want to deal with them. They need to be a part of it, because as soon as that patient exits the hospital or the clinical setting, the family is the one that's going to be providing the care. And they need to understand and know so they can provide good care and the patient doesn't have to return. So promote wound healing. So no matter what, we've created an incision, or there's an opening, or there's a wound, and this wound needs to heal. So how do we do it? Well, rest decreases the metabolic rate and allows nutrients to be used for healing. You need to allow the body to rest to heal. It has to, but it has to move. You know what I mean? So we're not out running races, but we are definitely walking when we need to, but we're definitely resting and having an afternoon nap, mid-morning nap, whatever we need to help. Proteins provide the building blocks of tissue. They need proteins in the diet. If they're not taking or eating those proteins, you can supplement with protein shakes. They're out there. They need probably something to give them the nutrients. Of course, you should be watching post-op their H&H, because we need blood. That's what transports our amino acids and other elements to the area. And so we want to make sure that everything is circulating like it should be, properly oxygenating the tissue like we should. So we need to understand that. Vitamin C is necessary for collagen production, the formulation of capillaries that bring blood to the healing of the tissues, and resistance to infection. What are your vitamin C foods? Well, foods that are high in vitamin C are citrus fruits and juices, strawberries, cantaloupe, tomatoes, bell peppers, cabbage, turnip and collard greens, broccoli, mangoes, I love, peaches, pineapple, and potatoes. Those are all high in vitamin C. Foods high in protein besides meat: cottage cheese, milk. Milk is high in sugar too, though, guys, so you got to remember that. Cheese, peanut butter, beans, eggs, ice cream, grain products such as breads and pastas, and then, of course, tofu and soy products. And just remember, with your elderly population, they're going to have vitamin and mineral deficiency, so they can have poor wound healing from that. They can be diabetics. We'll have poor wound healing from that. We want to control our blood sugars so that we can heal properly. Nutrition is huge, but on top of it, smoking will decrease the amount of hemoglobin available to carry oxygen to the healing tissues. So if they're smokers, they need to quit. They need to. While they're in the hospital, they can't smoke. So this is the time to put that patch on them and try to really promote it if you can, if they're willing. But explain to them it can cause poor wound healing. Steroids taken for a chronic condition will slow the healing process because they suppress the immune and inflammatory responses. Corticosteroids, if you take them for whatever reason, if a patient is on them, the surgeon needs to know it delays the healing process because it can suppress the immune inflammatory response. We take steroids for a lot of things, guys. I mean, your rheumatoid arthritis, things like that. We're going to take steroids. There's inflammation. We're taking steroids so that we can suppress the inflammatory piece of that. But when we take those, if we have to have surgery or anything like that, or any kind of wound, we are going to suppress wound healing. And the patients that are under that need to understand that. It also suppresses their immune system. So that's why during COVID, for people who have autoimmune disorders and diseases, a lot of them stayed home and stopped taking things that suppressed that because they were fearful of getting COVID and having, it killing them. And they were the ones that were at risk. A lot of them got really, really sick. So it is a concern. Just an FYI. Put that in your note. If you have not made a drug card on corticosteroids, you need to. You need to understand because they do a lot of different things. They're great. People love them. But they can cause a lot of problems. So we need to understand. Steroids save lives, though, too. So there's a need for them. And then, of course, minerals, zinc, copper, iron, assist in formation of the collagen. I just kind of talked. I'm not going to read these, but I just kind of talked about them. Factors that delay wound healing, something that you need to, as a student, look through, read, because guess what? These are the things you need to talk to or realize that your patient might have factors that delay their wound healing. Smoking is huge, number one on there. Mechanical injury from friction, pressure, or abrasion. Physical injury destroys granulation tissue if something happened physically to that tissue. If we have pathogenic organisms, it can delay it, anything coming into the wound. The steroids we talked about. And then excessive stress, apprehension, and emotional disturbances, they will make the body more vulnerable to invasion of foreign organisms by depressing the immune system. It's another way that we can depress the immune system is through excessive stress. Have you ever been? Yes, you have. You're in nursing school. What happens? You're at a high stress level. You're apprehensive. You're crying. You're doing all the things. You are susceptible of getting sick. That's why it's so vitally important you up your vitamin C intake. We do things to try to build the immune system or help support it when we have these things going on. Surgery alone is a stressor to the body. So we're already putting our bodies under stress just by having the surgery. The mechanical friction, pressure, and abrasion, when using such as a tape being removed, when you rip that tape back, it can disrupt the healing tissue and prolong wound healing. So be very careful in that. We don't want to be just ripping tape and doing this and causing that by mechanically doing something, physically doing it. Physical injury destroys granulation tissue, which is the framework on which new cells grow and mature to form or covering for the wound. So what happens is a wound will start to heal inside, granulating up. We don't want to physically injure that. That's why if you're removing a wet to dry dressing, you want to make sure you're pulling it to get the yuck out, but you also want to be very, very careful. Sometimes you'll re-wet it just to remove it. It's drawn up what needs to, but it's dried because you can rip, and you're going to rip that granulating tissue out. And that's the tissue that needs to be there. That's part of that healing. We want it to stay so that it can continue to granulate and heal up. You rip it out and you're just creating a new wound to heal, and we don't want that. The pathogenic organisms in a wound prolongs the inflammatory process and delays healing. But we can give anti-infective drugs post-op to prevent wound infection. So we can give things to hopefully prevent them from getting infection. So wound care, assessing swelling, formation of the hematoma, seroma, redness, tearing of the skin, and other signs of separation of edges of skin that have been sutured together. Aseptic technique is what we want to use when doing wound care, and standard precautions. Only if it is ordered for you to do sterile do you do sterile, but it's considered aseptic. Look up the words. If you don't know what seroma is, think about hematoma. That's a blood, right? Well, seroma, serous. Look those up. Look up your words. We've talked about wound care. You can go back and review that section if you need to. But we're looking for things. We don't want redness. We don't want warmth. We don't want streaking. Looking for signs of infection. So we want to make sure we have proper splinting of the wound to prevent dehiscence, and we'll go over that a little more in depth here in another little slideshow presentation. Vomiting, abdominal distension, and strenuous respiratory efforts such as coughing and forcefully exhaling breaths of air can cause dehiscence. So we want to make sure that we're splinting when we're doing any of those. Okay, if you have distension, you want to splint. Strenuous respiratory effort, vomiting, if you're gagging, coughing, when we do breathing exercises, deep breathing, when you're doing incentive spirometry, those things, and coughing, you want them to splint the incision. I'm going to stop here. It's an hour and 17 minutes into this lecture. I'm going to stop, and then I'm going to pick up into a second follow-up to finish out these last few slides.